Dear colleagues, I have to communicate with you under these difficult conditions, and I wish you all the best for facing this calamity. I was assigned by the organizers who had the kindness to ask me to participate in this meeting to cover the subject of androgens in menopause, and particularly what it has to do with hyperandrogenism beyond PCOS. So, I will outline my talk as follows. We will define menopause, then we will describe the androgenic profile in menopause. I will go over a certain number of slides with describing what happens with androgens in PCOS in menopause, and then I will cover the non-related to PCOS hyperandrogenism in menopause, and I will try to draw some conclusions out of this presentation. So, menopause is this state during the life of woman around the age of 50. For example, in Greece it happens as a median age at 51.2, and it is a long amenorrhea which has to be at least of 12 months, has to be followed by certain specific symptoms such as hot flashes. It is of use to consult this type of classification, which has been provided to us out of repeated workshops. This comes from 2012. It bears the name of STRAWS, describing the stages of reproductive aging workshop, and here you can see that menopause is defined according to the transition menopausal period which precedes menopause, and then postmenopause, which is distinguished in early and late. And I need to stress the fact that the late postmenopause, which deals with women over the age of 60 or 65, is not very well studied from the endocrinologic point of view. Now, let's see how is the androgenic profile during menopause in these women, and a lot of data come from big cohort studies. For example, this comes from the United States. It comprises both black and white women. White women are in dashed line, and it covers from the period of age starting at puberty and going over to the sixth decade of life. And we can all see that total testosterone, free testosterone, DHEAS, and androstenedione, they decrease during the age of menopause, and they continue like this thereon. However, they are not zero. So, postmenopausal ovary has to be considered as an active endocrine organ. It is estimated that postmenopausal ovary is associated with approximately 50% of total testosterone in about 30% of delta-4 androstenedione production. There is an increase of gonadotropins and of gonadotropin-dependent production of androgens from ovarian stroma, particularly because these androgens are under this stimulation by gonadotropins, which are increased during at least the early phase of postmenopause. Ovarian androgens decrease with age in late menopause, although this has to be further studied. I have to mention that the numbers regarding the amounts of androgen secreted by ovaries or adrenals in menopause are not very precise, and there are discrepancies in the literature. Also, we have to remember that there are other sources than the ovaries and, of course, the adrenals secreting androgens in postmenopausal women. And one of them is the pilosebaceous endocrine unit, as I am calling it, because androgens of not very strong activity, such as DHEA and androstenedione, they can go to these cells and can be transformed through enzymatic transformation to testosterone, which can even be transformed to the very extremely active dihydrotestosterone, which is active at the nuclear level. And from the clinical point of view, we can have this in mind because sometimes some clinical symptoms can be attributed to this transformation, and we can measure them by measuring 3-beta and 3-alpha diols either in the blood or the urines of these women. Now, how PCOS could be defined in menopause, because this sounds peculiar, since PCOS is defined at least regarding cyclicity of these women, and the cyclicity in polycystic ovarian syndrome is disturbed because most of these women, they present with oligomenorrhea or even amenorrhea. And one of the major features of these women is their hyperandrogenism, which can be not only of ovarian origin, which is the commonest source, but also of adrenal origin. However, because ovaries continue to secrete androgens even after menopause, and the stroma of these ovaries is extremely increased in women with PCOS, one might suspect that the effects of these androgens may continue even after menopause. And we'll see how even adrenals participate in this secretion. Our late good friend, one of the most important scientists regarding the study of PCOS, Renato Pasquale, had early mentioned that one should pay attention not to the early appearance of PCOS during puberty, during adolescence, but also on the effects of this syndrome when these women approach menopause and postmenopause, and this is one of the major interests of studies regarding PCOS in recent years. Now, is it easy to define PCOS in menopause? It's not easy enough. It's not well explored. It is under exploration in our days. There is a difficulty of definition of PCOS a posteriori after menopause because you have to go to files in the clinics. The phenotype is not very well studied. However, it represents a physiological model for the study of metabolism of the androgens in the absence of ovarian cyclicity, although we're not going to cover this subject in this talk. How is the androgenic profile of PCOS women during menopause? There have been many studies, mostly of cohorts, which went up to menopause and particularly premenopause, where it has been shown that DHEAS decreases in these women in parallel with the decrease in controls. Also, androstenedione, although decreasing, and DHEAS decreasing in these women, is higher than when compared to controls. And in studies, it has been shown that the basal levels of DHEAS, androstenedione, and even testosterone is higher when these levels of PCOS women were compared to healthy controls. So, yes, in PCOS women, androgens decrease, but they remain higher, statistically enough, when compared to healthy controls in different studies. We have we have tried to study the same thing here. For example, in this study of Schmidt, you can see that the authors could not show that testosterone and DHEAS were greater in PCOS women, probably because their number was not sufficient, but they have shown that free androgen index is increased as compared to healthy controls. And as I was telling you, we have tried to study the same androgens not in premenopause but in postmenopause in 20 women with PCOS, and they are matched controls regarding also their BMI, and we have found a statistically significant difference in all androgens in favor of PCOS, whereas sex hormone binding globulin, as expected in these women, was lower than their controls. Of course, this information confirmed what was suspected in the past by the previous studies, but what we did and were interested to find out is what is the origin of these adrenal androgens? Is it of adrenal origin or of ovarian origin? This is why we performed a 3-day dexamethasone suppression test, and we found that DHEAS and testosterone was completely suppressed after this 3 days of dexamethasone administration, both in PCOS women and control women in menopause, showing that these two androgens in PCOS comes from the adrenals. However, delta-4 androstenedione was not suppressed completely, showing that androstenedione is both provided in PCOS women from both adrenal and the ovaries. And yes, later on, Purunen has shown that in women who were in menopause and in PCOS compared to controls, when they administer to these women generates analogs to block the activity of LH and FSH, and performed a human chorionic gonadotropin test, that is an LHRH test. They found that indeed delta-4 androstenedione was increased in these women, and where this androstenedione was of ovarian origin. Now let's go to the etiologies having to do with hyperandrogenism non-related to PCOS in menopause, and we can divide these etiologies according to a nice review we have recently presented with Professor Juro Machud in Frontiers of Hormone Research, that hyperandrogenism of non-tumorous adrenal or ovarian etiologies can be often encountered and has not to be neglected. It can be related with obesity. I called it PCOS-like, but also endocrinopathies can be suspected. We must try to find out acromegaly and Cushing disease if they are hidden behind this hyperandrogenism. Hyperprolactinemia, prolactin stimulates adrenal secretion. Hyperthyroidism, in hyperthyroidism there is a decrease of renal excretion of androgens. And then we have to suspect ovarian hypertrichosis, which sometimes presents with a very sound symptomatic clinical appearance, which can be confused even with hyperandrogenism of tumorous origin. Of course, we must not neglect the inherited disorders such as PCOS and even non-classic congenital adrenal hyperplasia. It's not a wrong statement to say that it can be sometimes diagnosed even in menopause, because if it is a non-classic congenital adrenal hyperplasia of light appearance, if it has to do uh, uh, with low penetration of the effects of this change, it can be covered during the whole life by the levels of estrogens, and when estrogen disappear, then it comes up. So it has to be researched in the clinical workup. Exogenous etiologies can be pharmaceutical use, such as androgens. We must pay attention when spouses of women who use testosterone gels, they apply these gels and they don't wear gloves. Use of anti-epileptics, administration of glucocorticosteroids, and of course we have always to suspect uh, women who are perform overtraining, when they overexercise in resistance exercise training, and they might use anabolic steroids. Hyperandrogenism of tumorous adrenal or ovarian etiology is more rare. However, it has to be suspected and has to be researched because it can be deleterious and devastating for the life of the patient, particularly if it has to do with adrenocortical carcinomas. Ovarian tumors, if can be seen in the echogram like cystadenomas, they can be easily diagnosed. However, some of them, they are so small they cannot be even detected, and sampling, venous sampling might be needed, as it happens sometimes with Sertoli-Leydig cell tumors in the ovary. At last, we have tried to describe all this approach regarding postmenopausal hyperandrogenism in this chapter, and we have to go at first with medical history, clinical examination, and serum measuring of serum androgen levels. If testosterone is lower than 150 nanogram per deciliter, and the onset of hyperandrogenism is since puberty, then one might suspect polycystic ovarian syndrome, non-classic congenital adrenal hyperplasia, or even the increase of obesity. If this hyperandrogenism appeared recently during premenopause and menopause, then we have to distinguish between adrenal origin hyperandrogenism or growth hormone stimulated, and we have to perform the workups for Cushing syndrome and acromegaly and act accordingly. Now, if the symptoms are severe, if virilizations and rapid progression of the clinical appearance are in front of our eyes, develop in front of our eyes, and testosterone levels are over 150 nanogram per deciliter, then we can distinguish the etiologies regarding THEAS measurement. If the THEAS is lower than 700 nanogram per deciliter, then we might suspect ovarian origin, such as ovarian hypertrichosis or ovarian tumor. Sampling might be useful sometimes if imaging cannot be helpful. If the HAS, on the other hand, is greater than 700 nanogram per deciliter, we might need to use adrenal CT or MRI in order to look for adrenal carcinoma. If no tumor is found, then ovarian and or adrenal venous sampling might be needed, particularly in cases of the ovaries where we might look up for tumors which are really tiny. To conclude, the endocrine system undergoes major alteration during aging, affecting the majority of body functions. Many of these changes have been so far well described, but their exact impact on health and disease is yet to be unraveled. Regarding postmenopausal androgen secretion, it is important to differentiate between aging and pathology-associated alterations. Postmenopausal women with PCOS demonstrate at baseline higher levels of androgens than healthy controls. In postmenopausal PCOS women, testosterone and DHEAs are of adrenal origin, whereas delta-4 androstenedione production is of both ovarian. etiologic and or symptomatic, should be adapted to the diagnosis. And with this, I have to thank my collaborators for the development of this publication, and thank you for your attention.